Hello, my name is Erik Pedersen. I'm one of the neuroradiologists at Creighton University Medical Center, and I am going to talk to you about basic approach to head CT interpretation. So the first thing I should start off with is this is actually meant as a basic approach for beginning residents or for medical students. And obviously, as a experienced neuroradiologist, my search pattern and the way I look at a head CT is always informed by the clinical context of the patient's history. And so it's also informed by the knowledge of neuroanatomy and neuropathology that I've accumulated over the years. And so while this approach, I can't tell you everything that would be going through my mind normally as I'm looking at a head CT, but I can kind of give you the basic signposts of where to look and a general pattern with which to start. So that's what we're going to do. So before us, we have routine non-contrast head CT. This one was obtained from the emergency room on a patient who had a trauma. So what's included in our routine head CT? Well, there's two sets of images obtained in the axial plane. So we have one that has a reconstruction kernel and windowing that's appropriate for looking at the brain or the soft tissues. And then one that is reconstructed in a bone kernel set in a bone window that is appropriate for looking at the cranial structures and other kind of bony structures. So, and then we have sagittal and coronal reconstructions, respectively, here that are in a soft tissue kernel with soft tissue window and level settings that are optimized to look at the brain. So that's the routine head CT protocol. And so I do most of the heavy lifting off the axial images in terms of my basic search pattern. And so typically what I'll do is I'll start at the vertex and I will start by looking at the cerebral hemispheres and just basically kind of going through and assessing general symmetry. Since the brain is a bilaterally symmetric structure, we'll go through and we'll look for any kind of asymmetries, and then we make an assessment of the density of the brain itself. And what you'll notice is that there are different densities for different parts of the brain. Most importantly is an assessment of the difference between the densities of the gray matter structures and the white matter structures. So in the brain, most of the gray matter is in the cortex, right, along the outside of the brain. And you can see that if you look like right here, in this right frontal lobe, you can see that there's kind of higher density cortex, and the white matter, that's beneath that cortex is of lower density or lower attenuation. There are some deep gray structures in the brain, including the basal ganglia and the thalami, and those are also have that kind of gray matter density. You can see here's the head of the caudate nucleus and the putamen, and then you can see the white matter tracts running in between there. This is the anterior limb internal capsule, genu internal capsule, and then posterior limb internal capsule runs back here. So we do an overall assessment of the gray-white differentiation within both cerebral hemispheres. We pay special attention to the insular ribbons along the insular cortex here. You can see nice cortex, which is differentiated from the external and extreme capsule below. So everything looks symmetric on this brain. There's preservation of the gray-white differentiation throughout both the deep gray structures and in the cortical structures throughout both cerebral hemispheres. There's no mass effect. The midline is in the midline, right? There's no midline shift. You can see the falx here, right? With this reflection of dura that extends in the interhemispheric fissure. And you can see that if you draw a line from here to here, all the midline structures continue to line up in the midline all the way down, so there's no mass effect. There aren't any masses or fluid collections in the brain, right? So masses can be, or fluid collections can be in the brain parenchyma. We call that intraaxial, or they can be outside the brain. And we call that extraaxial. You know, one of the things we often look for in the clinical setting of trauma would be like hematomas, right? Like a subdural or epidural hematoma that you'll hear more about in this particular lecture series. And so we look around the convexities for subdural and epidural collections of any kind. And the brain parenchyma should really go right out to the skull. And in this patient with normal brain volume, it does. The coronal reconstructions are particularly useful for finding thin subdural collections at the convexities. So I tend to use these for that purpose, looking along the convexity for any subtle subdural collection. They can occasionally be missed on the axial images, just related to partial volume averaging. The sagittals are also helpful in that regard. And then the same can be said of subdural collections along the falx or along the tentorium cerebelli. Using these sagittal and coronal reconstructions can help you be more sensitive for detecting those. So we don't have any extraaxial collections. All the density of the brain structures looks normal. We're going to kind of continue to work our way down into the to the ventricle system, the ventricular system, which should be pretty symmetric. It's normal in size. We have the lateral ventricles and the third ventricle. The third ventricle hooks up to the fourth ventricle down here through the aqueduct of Sylvius, which can be seen on this sagittal view right here, with the tectum of the midbrain and the tegmentum of the midbrain over the top and under the floor. So all the ventricles look like they're normal in size, and everything there looks copacetic. We're going to look at the basal cisterns to make sure they're patent, right? The basal cisterns are part of the subarachnoid space. You get this large area here that's full of cerebrospinal fluid that can be seen here on the sagittal sequence and can be seen here on the coronal sequence. And that basically should be filled with vascular structures, the optic chiasm, the pituitary stalk, and CSF. When there's mass effect in the brain, these cisterns can get tight because the brain is trying to squeeze itself out of them. So this is the suprasellar cistern, this is the quadrigeminal plate cistern, and the kind of perimesencephalic cisterns, right? The cisterns around the midbrain, and those are all patent and look great. So, so we've assessed the basal cisterns. We're going to do one last check for subtle areas where we look for subarachnoid hemorrhage. That's going to be the interpeduncular cistern, which is this little space at the back of the suprasellar cistern between the cerebral peduncles. We're going to look at the dependent portions of the atria and occipital horns. Small amounts of hemorrhage can hide there, and if you don't look, you won't see them. And in the dependent portion of the sylvian fissures, which is going to be back here on both of these sides here. So those are three places that I always look for subtle subarachnoid hemorrhage, basically at the end of every study, particularly in a patient that has headaches that are unexplained. So the posterior fossa structures, CT is a fairly blunt instrument for their evaluation, but we look anyway. And so we've got the kind of midbrain structures here. We go down into the pons. We've got the middle cerebellar peduncles, the fourth ventricle, and then the right and left lobes of the cerebellum. We can actually see the cerebellar tonsils here on the sagittal view. They're above the level of the foramen magnum like they should be. Fourth ventricle looks normal in size. There's no posterior fossa mass effect. That all looks good. So the next thing we're going to do is we're going to assess the skull, and we're going to use the bone windows for that. So the skull looks intact. There are multiple little vascular structures, venous lakes, and venous channels extending through the skull. Those are all normal. We don't see any fractures, and we don't see any focal bony lesions. And then once we've assessed that, we're going to look at the extracranial structures, and that's where we kind of lump in looking at the other important structures in the head that we can see, like the orbits, including the globes and the optic nerve and sheath complex and extraocular muscles. The orbital fat should be nice and uniform and dark. And then we can look at the paranasal sinuses. So I like to use the bone windows for that. So we have the frontal sinuses here, the ethmoid sinuses, the sphenoid sinus, and then the bilateral maxillary sinus. This person has opacification of their right maxillary sinus with some high density material that is usually inspissated secretions. And then we can look at the mastoid air cells. These are normally aerated. You can see little bits of the inner ear structures here. Here are the cochlea on both sides. You can actually see some ossicles in the middle ear on both sides. Then we're just going to look at the bony structures of the face, and we're going to look at the structures of the skull base with some of the outlet foramina and vascular pathways, just to make sure that there aren't any lesions. And so then once we get to the bottom, we're basically done. And so that's just a basic search pattern for when you're looking at head CTs again. That's just kind of, those are the basic signposts on the road, and you know, the way you look at these is really informed by your knowledge of the kinds of things that exist in the brain normally and the kinds of things that can go wrong. But if you start with a basic search pattern, you can hang additional knowledge on that as you get more experienced. So thanks for your attention.